Welcome. In this session, we'll discuss exodeviations. An exodeviation is a divergent misalignment between the two eyes, which can be either manifest when it is called an exotropia or latent when it is called an exophoria. We have discussed the difference between tropias and phorias in the session on motor evaluation of a strabismus patient, and this photograph shows a patient with a manifest exodeviation, that is an exotropia. Risk factors for exodeviation include uncorrected refractive errors, maternal smoking or drug abuse, prematurity, perinatal complications, and genetic anomalies or a family history of strabismus. Pseudoexotropia is much less common than pseudoexotropia, and causes of pseudoexotropia include wide interpupillary distance and positive angle kappa. As we have discussed in previous sessions, the difference between strabismus and pseudostrabismus is that in pseudostrabismus we will not find movement of the eyes during cover tests, and on corneal light reflex tests the eyes will appear aligned except in pseudostrabismus due to an abnormal angle kappa. An exophoria is a latent exodeviation controlled by fusional convergence amplitudes during normal binocular viewing conditions. So during normal binocular viewing conditions, a patient with an exophoria will appear to have aligned eyes. But the deviation of an exophoria can be revealed by disruption of binocular fusion, such as during uncovered testing, alternate cover testing, and visual acuity testing. Patients with exophoria are usually asymptomatic, but they may have asthenopic symptoms during prolonged near work. An exophoric patient may demonstrate exotropia during illness or with the use of sedatives and alcohol. Broadly, exotropias can be classified as intermittent exotropias and constant exotropias. Under constant exotropias, we have several entities which we will be discussing individually. Intermittent exotropia is by far the most common exotropia. In a patient with intermittent exotropia, the alignment between the two eyes alternate between exotropia and orthotropia. Intermittent exotropia usually starts in childhood and has a gradual onset before 5 years of age, and the exotropia continues into adulthood. In the majority of intermittent exotropia patients, the exotropia develops from a preceding exophoria, and later the intermittent exotropia decompensates into a constant exotropia. In the remainder of the IXT patients, the deviation during the exotropic phase either remains stable or improves spontaneously. Because many patients with IXT can decompensate into a constant exotropia with an associated risk of developing amblyopia, IXT patients require long-term observation. Refractive error distribution in IXT patients are similar to that in the general population. In IXT, the exotropic periods usually occur with visual inattention, fatigue, stress, and illness. Exposure to bright light can provoke exotropia in a patient with intermittent exotropia, and on exposure to bright light, the child can be found to close one eye or rubbing his or her eyes. This closure of eye is called squinting, from where the term squint originates. In many patients with IXT, exotropia is found to be more in the distance, and since parents usually interact with children from near, there can be a delay in reporting the exodeviation. Since in intermittent exotropia there are periods of exotropia alternating with periods of orthotropia in young children, during the exotropic periods there is suppression with poor fusion and low-grade stereopsis, but during the orthotropic periods there is normal retinal correspondence and binocular function is excellent with high-grade stereopsis. Diplopia does not occur in young children with intermittent exotropia during the exotropic periods because of suppression, and amblyopia rarely occurs in intermittent exotropia because of the intervening orthotropic periods. But if an esophoria decompensates into intermittent exotropia in adulthood, diplopia does occur. In long-standing exotropia, Contracture of lateral rectus can occur, leading to incomitance of the exodeviation during the exotropic periods. Associated conditions in a patient with intermittent exotropia include small hypertropias, pattern strabismus along with their horizontal exodeviation, decreased exodeviation in lateral gaze, and over elevation or over depression in adduction. Pattern strabismus will discuss in a subsequent session. Decreased exodeviation in lateral gaze implies that the exodeviation measured in primary position is more than the exodeviation measured in either or both lateral gazes. Over elevation or over depression in an adducted position can be due to overaction of obliques, which, as we have seen in a previous session, can also be associated with infantile esotropia, or due to a tight lateral rectus muscle in a patient with a long-standing exotropia, and these two conditions can be differentiated by forced duction testing for the horizontal recti and the obliques. Control refers to the ability of an intermittent exotropia patient to intermittently align the eyes. Patients with poor control of intermittent exotropia and thus frequently manifest exotropia have increased risk of amblyopia and poor binocularity with low-grade stereopsis. The control of intermittent exotropia by the patient can be assessed and graded either by a home-based method or by clinic-based method. In the home-based method, if the parents report that the exotropia is manifest more than 50% of the time when the child fixates at distance, and exodeviation is also present when the child fixates at near, the control of intermittent exotropia is said to be poor. And if the parents report that the exotropia manifests more than 50% of the time when the child fixates at distance, but the exodeviation is not apparent when the child fixates at near, the control of intermittent exotropia is said to be moderate. And if the parents report that the child is exotropic less than 50% of the time when the child is fixating at distance, the control of intermittent exotropia is said to be good. And in the clinic-based grading, the rapidity of realignment is assessed after dissociating the two eyes for near fixation as well as for distance fixation. If realignment occurs immediately after dissociation, the control of IXT is excellent. And if realignment occurs with the first blink after dissociation, the control of IXT is said to be moderate. But if realignment after dissociation does not occur even after the first blink, then the control of IXT is said to be poor. So in a patient with intermittent exodeviation, we inquire about the age of onset of the exodeviation, frequency and duration of exotropic periods, which indicate the ability of the patient to control the intermittent exotropia, whether the exotropic periods are becoming more frequent and longer in duration with passage of time, situations which provoke exotropia, symptoms such as diplopia, which occurs in older children and adults, and asthenopia, and psychological issues arising from the misalignment of the two eyes. There is a specific sequence of examinations so that the binocular tests are done prior to disrupting fusion. The binocular sensory tests are done to evaluate stereopsis at both distance and near, and detecting anomalous retinal correspondence and suppression. Control of the exodeviation is then assessed as we have just discussed, and then the angle of deviation is measured first in the primary position for distance at 6 meters, for near at 33 centimeters, and sometimes further out in the distance at 30 meters. The angle of deviation for distance is also measured in left and right gazes and up and down gazes. Measurement in the up and down gazes detect pattern strabismus, and measurement in the left and right gazes detect those patients whose exodeviation in the primary position decreases in either or both lateral gazes. During measurement of the angle of deviation, we must note if there is any difference in magnitude of exodeviation for near fixation and distance fixation. And if exodeviation is not detected but the parents still complain of exodeviation at home, closure of one eye for 1 hour in the clinic and followed immediately by the alternate cover test can help in detecting the exotropia. Versions and ductions are then tested for detecting oblique muscle dysfunction and contracture of the lateral rectus muscle, and finally visual acuity is recorded. Classification of intermittent exotropia is based on the differences in the magnitudes of exotropia at distance fixation and at near fixation, and the difference between these two is best detected when the two measurements are taken following 1 hour of monocular occlusion. In the basic type of IXT, the exodeviations measured at near fixation and distance fixation are similar and are within 10 prism diopters of each other. So the magnitudes of distance exodeviation and near exodeviation are similar in the basic type of IXT. In divergence excess type intermittent exotropia, the exodeviation at distance is greater than exodeviation at near by at least 10 prism diopters. Divergence excess type intermittent exotropia can be due to a high AC by A ratio. So we may find high AC by A ratio in patients with accommodative esotropia as well as in patients with divergence excess type of intermittent exotropia. In the former, we will find esotropia at near more than esotropia at distance, and in the latter we will find exotropia at distance more than exotropia at near. Divergence excess intermittent exotropia with high AC by A ratio can be diagnosed when the exotropia at distance decreases by 12 prism diopters or more when -2 diopter spherical lenses are placed before both the eyes. Minus powered lenses make the eyes hyperopic and induces accommodation. Along with this accommodation, accommodative convergence, which is abnormally high in patients with high AC by A ratio, is also induced, and this high accommodative convergence reduces the exotropia at distance in these patients significantly. And patients with divergence excess intermittent exotropia with high AC by A ratio may develop esotropia at near following surgical correction of exotropia, for which they may require bifocal glasses. On initial examination, a divergence excess IXT can resemble a basic type IXT with the measured deviations at near and distance fixations being similar. But following 1 hour of monocular occlusion, the underlying divergence excess will be revealed and we will be able to diagnose the true divergence excess nature of the intermittent exotropia. The opposite can also happen, that in basic intermittent exotropia due to a tenacious proximal fusion, the exodeviation at near fixation may appear to be less than in the distance, and this is called pseudo-divergence excess in basic intermittent exotropia. And in this situation also, following 1 hour of monocular occlusion, the near distance discrepancy due to tenacious proximal fusion disappears in pseudo-divergence excess but does not disappear in true divergence excess. So 1 hour of monocular occlusion can help in distinguishing between true divergence excess and true basic type of intermittent exotropias. In convergence insufficiency type of intermittent exotropia, the exodeviation measured at near fixation is greater than the exodeviation measured at distance fixation by 10 prism diopters or more, and this is said to be due to poor fusional convergence amplitudes, and so these patients demonstrate a remote near point of convergence. These patients can complain of asthenopia, blurred vision, and diplopia during near work. So we have three types of intermittent exotropia: basic intermittent exotropia, in which the exotropia at distance is similar to the exotropia at near; divergence excess intermittent exotropia, in which exotropia at distance is greater than exotropia at near; and convergence insufficiency intermittent exotropia, in which exotropia at near is greater than exotropia at distance. Patients with asymptomatic, well-controlled intermittent exotropia can be observed without treatment. But if the control of intermittent exotropia is moderate to poor, the patient should be treated either by non-surgical measures or by surgical correction. Non-surgical measures include refractive error correction, prisms, occlusion therapy, and orthoptic exercises. If non-surgical measures fail to control the exodeviation adequately, surgical correction of the exodeviation will be required. Refractive error correction is an important non-surgical treatment measure for intermittent exotropia. In patients with intermittent exotropia and having myopia, even if the myopic refractive error is mild, the myopic refractive error should be fully corrected. This is because making a myopic patient emmetropic for distance will make the patient induce accommodation for targets nearer than the standard 6 meters, and along with this accommodation, accommodative convergence will also be induced, which will help control the exodeviation of IXT. Some recommend overcorrection of myopia by 2 to 4 diopters to stimulate accommodation and accommodative convergence, but this may not be a feasible option for school-going children because hyperopic refractive error of 2 to 4 diopters for distance may make it difficult for the patient to focus on distant targets. But in IXT patients with mild to moderate hyperopia, the refractive error is left uncorrected. Because this mild to moderate hyperopic refractive error for distance will make the patient induce accommodation, and simultaneously accommodative convergence will also be induced to control the exodeviation of IXT. And in intermittent exotropia patients with high hyperopia, their high hyperopic refractive error should be partially corrected, because if this high hyperopic refractive error for distance is not corrected, the patient will not be able to focus distant objects even after induction of maximal accommodation, and so the accommodative effort will not be sustained, and thus along with it accommodative convergence effort will also not be sustained to control the exodeviation of intermittent exotropia. Part-time occlusion therapy can temporarily control small to moderate exodeviations in young children even if amblyopia is not present. And for this, part-time patching of dominant non-deviating eye when there is ocular preference, or part-time alternate patching of each eye when there is no ocular preference is prescribed. Orthoptic exercises such as pencil push-ups may help young patients with symptomatic convergence insufficiency to get rid of their asthenopic symptoms. Prisms may be beneficial in adults with intermittent exotropia, and for this purpose basin prisms on the near segment of spectacles are prescribed to adult patients with convergence insufficiency, particularly those who complain of diplopia at near fixation. However, prism should not be prescribed in younger patients, because with a basin prism the patient will not require to induce convergence, and thus basin prisms in younger patients may reduce their fusional convergence amplitudes. And with progressive reduction in the fusional convergence amplitudes, progressively stronger prisms will be required in these patients to control their exotropia, and this is called eating of the prism. Indications for surgical correction of intermittent exotropia include failure of non-surgical measures to efficiently control the intermittent exotropia, a frequently manifest intermittent exotropia with exotropic periods occurring more than 50% of waking hours, worsening of the exodeviation with passage of time, especially worsening of exodeviation at near fixation, decompensation to constant exotropia, decreasing stereo acuity, occurrence of symptoms such as asthenopia, diplopia, squinting and rubbing, and a poor self-image due to misalignment of the two eyes. Among these indications, these two are the important ones to remember. There is no consensus about when surgery should be performed to correct the exodeviation of intermittent exotropia, but excessive delay in surgical correction can compromise surgical results by causing contracture of lateral rectus muscle. Usually bilateral recession of lateral rectus muscle is done. Less commonly, a unilateral procedure combining recession of lateral rectus muscle with resection of ipsilateral medial rectus muscle, or a bilateral resection of medial rectus muscles of both eyes is done. Recession of lateral rectus muscle weakens the lateral rectus muscle, and the lateral rectus muscle being an abductor of the eye, weakening of the lateral rectus muscle decreases the outward deviation of the eye. And in a resection procedure of a medial rectus muscle, the medial rectus muscle is strengthened, and medial rectus being an adductor of the eye, the outward deviation of the eye in an exodeviation is reduced. Large angle exodeviation of more than 50 prism diopters may require surgery on 3 or 4 horizontal muscles. So we have a surgical dosage chart for correcting exodeviations also, in which the amount of lateral rectus resection required in millimeters and the amount of medial rectus resection required in millimeters are given for corresponding amounts of exodeviation measured in prism diopters. Caution is required in 2 scenarios of intermittent exotropia undergoing surgical correction of their exodeviation. In true divergence excess with high AC by A ratio, correcting the maximal deviation at distance may lead to post-operative esotropia for near fixation, and these patients will thus require correction of this post-operative near esotropia with bifocal spectacles. And in patients in whom the exodeviation in primary position decreases by 10 prism diopters or more in either or both lateral gaze positions, 1 mm less LR recession should be done on the eye in the side of the gaze with less exodeviation. Successful outcome of surgical correction of exodeviation in intermittent exotropia is defined as achieving alignment to within 10 prism diopters of orthotropia. Following surgical correction of exotropia, post-operative esotropia or exotropia can occur. Post-operative esotropia can be due to the small targeted overcorrection which improves maintenance of alignment long term, but this overcorrection disappears within a few weeks following the surgery. Esotropia from lost or slipped lateral rectus muscle should be intervened with immediately. Otherwise, surgical correction of the post-operative esotropia should be delayed for 6 months, as the consecutive esotropia may disappear spontaneously with time. And in the long term after surgery, exotropia can recur and several surgeries may be required to maintain alignment. Apart from surgery, injections can be given to the horizontal rectus muscles to control exotropia. Botulinum toxin can be given to the lateral rectus muscle to weaken that muscle, and bupivacaine injection can be given to the medial rectus muscle to strengthen that muscle. There are several exotropia entities which can be described as constant exotropia. As in intermittent exotropia, a constant exotropia can also demonstrate near distance discrepancy in their magnitude of deviation. And so these constant exotropias can also be either basic, true divergence excess, or pseudo-divergence excess exotropia. Patients with constant exotropia may have enlarged visual fields due to large areas of non-overlapping visual fields, and following surgical correction, they may perceive constriction of their visual fields. Surgical treatment of constant exotropia is same as the surgical treatment of intermittent exotropia, including the surgical dosage. An intermittent exotropia may decompensate into a constant exotropia, and this can occur in an untreated long-standing intermittent exotropia. Infantile exotropia is a constant large angle exotropia occurring before 6 months of age. So this figure is the same as in infantile esotropia. However, infantile exotropia is much less common than infantile esotropia. Like infantile esotropia, infantile exotropia patients can have inferior oblique overactions or dissociated deviations, but latent nystagmus is uncommon in patients with infantile exotropia. Patient with an infantile exotropia has a higher chance of developing amblyopia as compared to a patient with intermittent exotropia because of the constant nature of infantile exotropia. Neurological impairment and craniofacial disorders are known risk factors for infantile exotropia, and as in infantile esotropia, surgical treatment for correcting the exodeviation of infantile exotropia is recommended before 2 years of age. And following surgical treatment, infantile exotropia patients usually achieve monofixation instead of bifoveal fusion, and this achievement of monofixation is considered as a favorable outcome as following surgical correction of infantile esotropia. Sensory exotropia occurs following loss of vision in one or both eyes. These two photographs show a patient with sensory exotropia of the left eye due to loss of vision following congenital retinal toxoplasmosis. Sensory exotropia and sensory esotropia are equally common in young children, but sensory exotropia is more common than sensory esotropia in older children and adults. If vision, at least peripheral vision, can be restored, peripheral fusion can maintain alignment following subsequent strabismus surgery for the exotropia. And the usual scenario of this occurring is in a patient having sensory exotropia because of cataract. But if vision restoration is done late in adult onset sensory exotropia, a phenomenon called central fusion disruption may occur in which central fusion never develops. And in patients with central fusion disruption following strabismus surgery for ocular alignment, patient perceives persistent diplopia despite perfect ocular alignment. Consecutive exotropia occurs following a period of esotropia. Rarely consecutive exotropia can occur spontaneously, but more commonly consecutive exotropia occurs following surgical correction of esotropia. Convergence paralysis is an entity distinct from convergence insufficiency type of intermittent exotropia, and convergence paralysis is usually secondary to an intracranial lesion, most commonly dorsal midbrain syndrome. In convergence paralysis, exotropia and diplopia occur at near fixation only, but adduction and accommodation are found to be normal. They are usually treated with basin prisms at near to correct their diplopia at near fixation. But true convergence paralysis should be distinguished from malingerers displaying convergence paralysis. And in malingerers, their pupils will not constrict when they are asked to fixate at near because they will not give an effort to induce the near reflex. Causes of incomitant exotropia include exotropic or type 2 Duane's syndrome, third cranial nerve palsy causing weakness of the medial rectus muscle, internuclear ophthalmoplegia, particularly the wall-eyed bilateral internuclear ophthalmoplegia type, myasthenia gravis, and dissociated horizontal deviation. In dissociated horizontal deviation, there is a slow abduction movement of one eye only, and it is not a true exotropia, and it may be associated with infantile esotropia. And in this situation, dissociated vertical deviation and latent nystagmus can also be found. To recap the salient points, exotropia is a divergent misalignment of the eyes. Pseudoexotropia can occur due to a wide interpupillary distance or positive angle kappa. Intermittent exotropia is the most common type of exotropia with onset usually before 5 years of age. In most cases of intermittent exotropia, exotropia is preceded by a period of exophoria, and the intermittent exotropia ultimately decompensates into a constant exotropia. Symptoms of intermittent exotropia include squinting and rubbing the eyes in bright light. Diplopia and amblyopia occur rarely in patients with intermittent exotropia. Intermittent exotropia can be basic, divergence excess, or convergence insufficiency types, depending on the near distance discrepancy of the magnitude of deviation measured at near fixation and at distance fixation. Non-surgical treatment of intermittent exotropia includes refractive correction, which includes full or overcorrection of myopia, undercorrection of high hyperopia, and leaving mild hyperopia uncorrected, as well as orthoptic exercises for patients with convergence insufficiency. Surgical treatment of intermittent exotropia is indicated when non-surgical measures cannot control the deviation efficiently, when exotropic periods occur more than 50% of waking hours, when there is worsening of the exodeviation with passage of time, and when the intermittent exotropia decompensates to a constant exotropia. Most commonly, bilateral recession of lateral rectus muscle is done. Constant exotropia can be of various types, including decompensated intermittent exotropia, infantile exotropia, sensory exotropia, consecutive exotropia, and convergence paralysis. Infantile exotropia manifests before 6 months of age and should be surgically corrected before 2 years of age. Sensory exotropia occurs due to loss of vision in one or both eyes. If correction of the cause can restore vision, at least peripheral fusion, then alignment can be maintained after subsequent surgical correction of exotropia. Consecutive exotropia is exotropia occurring after a period of esotropia, which can occur either spontaneously or much more commonly following surgical correction of esotropia. Convergence paralysis is usually caused by an intracranial lesion, usually dorsal midbrain syndrome. Thank you for listening.